Greetings, dear colleagues. Today I want to talk with you about differential diagnosis of the respiratory tuberculosis. In the pathology of the respiratory organs, there are many diseases that are very reminiscent of the primary tuberculosis complex and tuberculosis of the intrathoracic lymph nodes. The first disease is lympholeukosis, and the radiographic picture of enlarged tumor-like root lymph nodes resembles that of tuberculosis bronchiolitis. Characterized by a tumor-like increase in both roots of the lungs, lymph nodes of the upper mediastinum, as a result of which its normal radiological picture is lost. Important for the diagnosis of leukemia is the picture of the white blood, a sharp increase of lymphocytes in the smear, young and pathological forms of lymphocytes, lymphoblasts, the results of bone marrow tissue biopsy. Sometimes, in the lung with leukemia, there is an overgrowth of lymphoid tissue, which on X-ray examination is displayed in the form of miliary striated or infiltrate-like shadows. The picture resembles that of pulmonary tuberculosis. On the other hand, some forms of tuberculosis can occur with a leukemioid reaction. However, its reaction is not stable, transient, and unlike lymphocytic leukemia in patients with a leukemioid reaction, in tuberculosis there are no immature forms of leukocytes in the white blood picture. And negative tuberculin tests. The next one is non-specific pneumonia. Is known to be a very common disease in children. Regardless of the etiology, it proceeds in them according to the type of lobar, lobular, or interstitial. The common symptoms are cough, chest pain, fever, and hemoptysis. The proteinogram has approximately the same character, a decrease in the albumin-globulin ratio due to a slight decrease in albumins and an increase in globulins. More acutely with symptoms of previous catarrh of the upper respiratory tract, increase in the level of leukocytes, neutrophils, and decrease in the level of lymphocytes. On X-ray examination, paravertebral pneumonia often gives shadows that are difficult to distinguish from hilar infiltrates in the lungs. At the same time, extensive shading is often found that extends to the entire paramediastinal space, in which it is possible to distinguish the boundaries of the cardiovascular shadow. Rapid. Within 12–40 days, the positive dynamics of clinical manifestations and especially radiological signs of the disease under the influence of antipneumonic or anti-inflammatory treatment indicates its non-specific nature. Important. With bronchopneumonia, the shadow of the lung root can be enlarged, but unlike tuberculosis bronchiolitis, infiltratiform, with pneumonia, it is not so compact and intense, it quickly undergoes regression. The next disease is lymphogranulomatosis. The common symptoms are general weakness, weight loss, night sweats, subfebrile temperature, and sometimes febrile with characteristic periods of outbreaks and remissions. Lymph nodes in both roots of the lungs are more often affected, as well as the peripheral lymph nodes, cervical and supraclavicular, with tuberculosis unilateral intrathoracic lymphadenopathy. With lymphogranulomatosis, a symmetrical lesion of the paratracheal lymph nodes is observed, a symptom of the chimney. Lymph nodes reach large size. With exacerbation, a higher temperature with wave-like character, itching, night sweats, up to torrential, and the general condition of patients is worse than with bronchiolitis. With lymphogranulomatosis, we can see an increase of the level of leukocytes. With lymphogranulomatosis, the effect can be obtained especially at the first stages of treatment from glucocorticoids, cytostatics, X-ray therapy. Biopsy of intrathoracic or peripheral lymph nodes is of great importance. Cytological or histological tests make it possible to identify Berezovsky-Steinberg cells in patients with lymphogranulomatosis, specific granulomas and caseosis mazes in tuberculosis. Beck's sarcoidosis. Weisner-Beck-Schaumann disease is a systemic disease manifested most often by the formation in the intrathoracic lymph nodes and light epithelioid giant cell granulomas without caseosis. Etiopathogenesis is not fully understood. Many researchers associate the disease with the impact on the human body of modified forms of the causative agent of tuberculosis, the same as L4. Decreased cellular immunity plays an important role in the pathogenesis of the sarcoidosis. Most often, the course of the disease is asymptomatic. Usually, patients are detected during fluorography. To verify the diagnosis, bronchoscopy with transbronchial puncture of the lymph nodes is performed, and occasionally mediastinoscopy. In histological examination in patients with sarcoidosis, the changes are rarely reminiscent of the picture in tuberculosis granuloma. Epithelioid cells and, in some cases, giant cells of the Pirogov-Langhans type are found. X-ray usually detects a bilateral tumor-like enlargement of the lymph nodes in both roots of the lungs. With tuberculous bronchodinitis, changes are unilateral. The X-ray picture of polycyclic contours of enlarged shadows of the roots clearly delimited from the lung fields is characteristic. The next disease is carcinomatosis, a miliary carcinoma of the lungs. Always a metastatic process. Most carcinomas or sarcomas can metastasize to the lungs. More often, it is cancer of the stomach, breast, cancer of the head of the pancreas, hypernephroma, seminoma, chorion epithelioma. Common symptoms are weakness, poor appetite, weight loss, cough, shortness of breath, chest pain, poor physical condition, and sometimes fever. Patients with carcinomatosis are usually elderly, although it often develops at the age of 30–50. Radiologically, with lung carcinomatosis, there is a characteristic dense, small focal dissemination as in disseminated pulmonary tuberculosis. But the foci in carcinomatosis are large, localized in the lower and middle sections of the lung fields and more densely in the basal zones, without perifocal inflammation. On radiographs taken 10–20 days after the previous ones, in patients with carcinomatosis, there is an increase in changes in the lungs. On this slide, you can see the table of ratios between the content of protein and glucose in the exudate. Central lung cancer and pulmonary tuberculosis in the initial stage can be hidden. Symptoms and risk factors of central lung cancer are cough, hemoptysis, shortness of breath, fatigue, increased erythrocyte sedimentation rate, chronic non-specific respiratory diseases, long-term smoking, dullness of percussion sound in patients with lung cancer is more pronounced. Clinical course is characterized begins more slowly than tuberculosis. With the progression of the disease, the deterioration of the general condition increases. Weakness, fatigue, weight loss, characterized by dry cough or white, a small amount of sputum, a hacking cough. Hemoptysis in lung cancer is longer persistent. When the tumor grows into the pleura, there are constant intense pain in the chest. X-ray reveals changes in the root zone with upper lobe localization, more often in the third segment. The outer contour of the shadow node is fuzzy, uneven, characterized by the presence of radiant cords, depending on cancerous lymphangitis. Symptom of crow's foot, rising sun. Areas of hypoventilation which can be mistaken for tuberculosis or pneumonic foci. As a result of anti-inflammatory treatment, it is possible to obtain temporary positive dynamics. Associated with the resorption of the focus of pneumonia, a decrease in hypoventilation due to elimination of edema around the cancer node in the bronchus, or the collapse of the tumor. However, after some time, hypoventilation is again detected and then atelectasis develops faster with endobronchial tumor growth and later with exobronchial growth. Bronchoscopy is important, which allows to detect a tumor or narrowing and decrease in the mobility of the bronchus. The next one, acute lung abscess. There are difficulties in its differential diagnosis with infiltrative tuberculosis in the decay phase. The common symptoms is fever, cough with sputum, sometimes hemoptysis, impaired general condition, the presence of wheezing, changes in the hemogram. Identification on a decay cavity during X-ray examination, acute onset with an abscess with several clinical manifestations, high temperature, chills, and sweats. An increase in the level of leukocytes, a sharply increased ESR, a pronounced shift of the left of the leukocyte form. At the same time of the breakthrough of the abscess, a significant amount of purulent sputum is released, often with a putrid odor, which helps the correct diagnosis, since sputum is odorless in tuberculosis. An X-ray examination in typical cases reveals a decay cavity with a horizontal fluid level, which is rare in tuberculosis, with a wide shading band around the cavity, a blurry outer and uneven inner contour, and localization in the middle segments of the lung. It is especially difficult to differentiate a cavity of non-specific etiology from a tuberculous one when it is located in the upper sections of the lungs. There is no fluid level with mild clinical manifestations. It is necessary to repeatedly examine the sputum and epithelial lining fluid, the X-ray picture with the absence of old and fresh tuberculosis foci around the cavity and other parts of the lungs. In the presence of cavity formation and anti-inflammatory treatment, it is advisable to conduct a control X-ray examination no earlier than 3 weeks later. Lung infarction has to be differentiated from infiltrative tuberculosis. Patients with pulmonary infection have a history of phlebitis, thrombophlebitis, especially of the veins of the lower extremities. The disease begins acutely, chest pains are characteristic, often severe hemoptysis, much more often than with infiltrative tuberculosis. An increase in temperature may not be observed from the first day. Pulmonary infarction is often complicated by pleurisy, with pleural murmur first heard, then weakened breathing. The nature of the exudate in most cases hemorrhagic. Mycobacterium tuberculosis in sputum is not detected. Tuberculin tests may be negative. These coagulograms indicate a tendency to hypercoagulability. X-ray in different parts of the lungs with a heart attack, one or more shadows are detected, often triangular in shape, located in different parts of the lungs without destruction. There are no fresh nor focal changes. Carrying out anticoagulant therapy in combination with antipneumonic treatment is effective. Differential diagnosis of globular formations of the lung, round infiltrate tuberculoma. The term spherical formation implies the presence of a single, rounded pathological focus with more or less outlined contours located against the background of little lung tissue. The main signs of many diseases of this group is the absence of clear clinical symptoms in the presence of a spherical shadow in the lung. As a result, their diagnosis is extremely difficult and at the same time very responsible, since the probability of the malignant nature of the spherical shadow is very real. Not only treatment, but in some cases the rate of the patient depends on the reliability of the diagnosis. Therefore, based on clinical and radiological data, the diagnosis must be confirmed by the results of bacteriological, cytological, or histological tests. Only a confirmed, verified diagnosis will allow the doctor to choose the right treatment tactics. The first disease is globular pneumonia. Begins acutely, catheter of the upper respiratory tract in the form of a runny nose, tonsillitis, bronchitis, violation of the general condition, fever is more pronounced. Patients with a round infiltrate and tuberculosis often feel completely healthy. The pulmonary process is detected in turn during a preventive X-ray examination. Changes in the blood, leukocytosis, increased erythrocyte sedimentation rate are more pronounced in pneumonia. However, it should be remembered that spherical pneumonia can also occur without clinical manifestations and be an X-ray finding. In such cases, the appointment of anti-inflammatory treatment and repeated X-ray examination after 10-12 days help to correctly establish the diagnosis. In the X-ray image, spherical pneumonia differs from round infiltrates and even more so tuberculoma in a less clear outer contour, less intensity of the shadow, and its greater uniformity. Focal shadows around spherical pneumonia are usually absent. The second one is peripheral cancer. In the analysis, we can see some risk factors as frequent bronchitis, abscesses, smoking for many years. Cough dry, prolonged hacking, chest pain is more common than in patients with tuberculosis. Shortness of breath is a fairly early symptom. More often, sputum is secreted, usually mucous, liquid, sometimes with an admixture of streaks of blood. A valuable differential diagnostic symptom is the presence in the sputum of individual erythrocytes or their clusters. More appropriate for suspected peripheral cancer growth from small bronchi fibrobronchoscopy. If peripheral lung cancer is suspected, a multiply examination of sputum and epithelial lining fluid for a typical cell should be performed. Peripheral lung cancer gives a display in the form of a shadow of a round or oval shape, and the intensity of the shadows is mainly determined by the volume of the pathological formation. However, as in tuberculoma, nevertheless, a significant intensity of the shadow is more characteristic of the cancerous tumor. The outlines of the shadow of peripheral lung cancer are not always clear. In most cases, wavy, small healing. With tuberculosis, the contours of the shadow are usually more even. Along with this, unevenness is noted due to radiance along the contours of the shadow of the cancerous formation. The combination of the symptoms, tuberosity and radiance, is an important evidence of the presence of peripheral lung cancer. In hematological examination, we can find pathological granularity in the protoplasm of neutrophils. The next one is lung cysts. Fillet lung cysts can also simulate tuberculosis or round infiltrates, and these differential diagnosis often present significant difficulties. Lung cysts are congenital and acute. The former are developmental normally and usually occur in children of tender years. Acquired cysts arise and develop on the basis of past inflammatory processes, as well as after a test in urine. Closed cysts are filled with fluid. In many cases, they are generally asymptomatic and are detected only by X-ray examination. They look like rounded or oval, homogeneous, clearly contoured shadow formations usually located among healthy, unchanged lung tissue. Cysts are located in various parts of the lung fields, in their peripheral sections, often in the deep layers of the lung. The following symptoms may help in the differential diagnosis. In favor of the diagnosis of a cyst, the change in the shape of the shadow detected during X-ray examination, fluoroscopy, at various phases of respiration, speaks in favor of the diagnosis of the cysts. A shadow of a regular rounded shape with clear contours. And the most frequent localization of cysts is the middle sections of the lung fields, especially on the left. Echinococcus of the lung. Echinococcus of the lungs, according to the X-ray picture, may be the reason of a differential diagnosis from tuberculosis. Clinical symptoms of pulmonary echinococcus are not typical and do not allow to differentiate echinococcus from other pulmonary diseases. Therefore, many authors recommended using the naming of symptom, breathing shadow, for diagnosing an echinococcal bladder. During a deep breath, the shadow of the cyst loses its rounded shape, becomes oval. On inhalation, it takes on its former shape. In the blood, eosinophila. In differential diagnosis, one should also pay attention to the localization of the shadow. A frequent location of echinococcus is the lower lobe of the right lung, and the lung tissue around the cyst is usually not changed. There are no signs of previous tuberculosis. When the echinococcal bladder bursts into the bronchus, a significant amount of a transparent yellow liquid is immediately separated. Microscopic examination reveals scoliosis hooks of echinococcus. You should also pay attention to the territorial and professional history, as well as keeping animals at home living in areas with the spread of echinococcal disease, more often in southern regions of our country. On this slide, you can see different forms of lung cavity formations. Chronic abscess. The criterion for the transition of an acute abscess to a chronic form is conditionally considered a 2-month period, which is more correct to calculate not from the onset of the disease, but from the moment of intensive treatment. In the analysis, there is often the presence of acute pneumonia, acute lung abscess, the treatment of which did not give a full effect. In clinical remission, a chronic abscess is almost asymptomatic, or there is a small cough with scanty mucus or mucopurulent sputum. Sometimes there are many persistent hemoptysis. In more severe patients, there is a weight loss, shortness of breath during a physical exertion, fingers in the form of drumsticks. Physical data are not very informative. On X-ray in patients with chronic abscess, there is a site of pneumosclerosis and a cavity, usually of an irregular shape, better defined on tomograms. The bronchi around the cavity are deformed, sometimes dilated. Localization of the abscess is more often in the middle or lower sections of the lung, while the upper sections may be completely intact. In laboratory tests, pathogens of non-specific infections are found in sputum: pneumococcus, staphylococcus, streptococcus. Tuberculin tests are negative in most cases. In difficult to diagnose cases, the decisive factor is anti-inflammatory therapy, which as a rule leads to a positive effect after 50–20 days from the start of the treatment. With cavernous tuberculosis, clinical manifestations are minimal. With fibrous cavernous tuberculosis, pallor and weight loss are often noted. On examination, one half of the chest lacks in breathing, shortening or dullness of percussion sound, fine bubbling or various wet rails. In the presence of large cavities, bronchial amphoric breathing. The same changes are sometimes detected in chronic abscess, but they are less pronounced. Fibrous cavernous tuberculosis reveals against the background of fibrosis deformed thick-walled cavities in the upper parts of the lungs. The corresponding lung field is narrowed in volume. The trachea and main bronchi are displaced towards the lesion. The pleura is compacted. In case of cavernous tuberculosis, an isolated thin-walled cavity without infiltration around and without bronchogenic staining is determined radiographically. Sometimes single focal shadows are revealed around the cavity. Bronchoscopically, endobronchitis is often detected, most pronounced in the zone of the draining bronchus. Functional disorders are more pronounced in fibrous cavernous tuberculosis. Bronchoectatic disease. The decisive role in one set of the disease is played by the genetically determined interiority of the bronchial tree, congenital weakness of the bronchial wall, insufficient development of smooth muscles, elastic and cartilaginous tissue. Among patients with bronchiectasis, men predominate. Often the starting point of the disease is pneumonia transferred at an early age. The main complaint is cough with purulent sputum. The most abundant expectoration of sputum is noted in the morning. Some patients have chest pain associated with pleural changes. Subfebrile or febrile fever, usually during an exuberation. High fever is relieved by expectoration of profuse stagnant sputum. The appearances of most patients with severe coughs is cyanosis, drumsticks, puffiness of the face, acrocyanosis, barrel-shaped chest. Patients with fibrous cavernous tuberculosis are characterized by pallor of the skin, weight loss, a staining chest. Fingers in the form of drumsticks are less common. The course of disease, periodic exacerbations, mainly spring and autumn, followed by longer remissions. Most often the basal segments of the left lung and the middle lobe on the right are affected. Physical examinations. On auscultation in the area of ectasias, there are large and medium bubbling trails as well as hard breathing. Shadows of the atelectatic lower lobes often appear as triangles adjacent to the lower mediastinum. Sometimes it is possible to identify the middle lobe syndrome, a reduced in volume and compacted middle lobe. On the later radiograph looks like a characteristic blackout band 2–5 cm wide, running from the root to the anterior costophrenic sinus. The main method confirming the presence and clarifying the localization of bronchiectasis is bronchography, the characteristic picture of which is compared with a bundle of rods or a chopped broom. At the same time, both cylindrical and saccular bronchiectasis are detected. Dear colleagues, thank you for your attention. Goodbye.